Very nice.
So how can I remove your face? I don't know. Okay. So how to perform, how I do perform my osteotomies. So I heard a little bit of the Pedro presentation, and of course, there are already some details that were done. So I will present you what we do for a regular osteotomy. So first of all, the clinical exam, of course, is very important, and to be sure that the patient we operate really need an osteotomy. I got one patient a couple of years ago. The patient was sent, he was 17 years old, and he was kyphotic, and just because of pain. But the X-ray was taken in kyphotic position, and it's not this patient. And so he was referred to me to do a PSO, and it was only a psychiatric problem, and the guy was standing with the kyphosis and say that he had pain, and people want to do an osteotomy. So it doesn't work like this. The clinical exam is really very important to do. And the dynamics X-rays are very, very important. And using what is called a fulcrum test, or the hypomocleon for the German, to put something on the table, and the patient is lying on the table to see if there is some reducibility of the deformity. This is very important because sometimes you already gain 50% of the deformity. So what you have to do is not a PSO, but only a multiple SPO. So this is very important. In the last 10 years, too many PSO were performed just because people didn't perform the right examination before the surgery. So this is very important. Of course, we need to have a CT scan and MRI. And when you can see a patient like this one, when the three last levels are already totally fused, and you have a gas on the level above on the CT scan, for sure, if you want to restore some kind of a better low doses there, you will have to do a PSO. So the indication is very important. A good clinical examination is really also very important before the surgeries. And when we do PSO, we always have to take attention to other things. Sometimes you have to remove a disc herniation, sometimes you have to remove stenosis, and this had to be done during the surgery, otherwise you will have a lot of problems. This was the first planification I did to try to obtain good results. And at this time I took the C7 because the C7 vertebra was the reference at this time. We know today that it's not the C7 anymore. You have to take C2 to avoid the PGKs on top of the correction we do. But this was the first one. So this is the first drawing I presented during the European spine, and it was in 2012. And it was very useful in our practice to determine the amount of correction we need to do a PSO. The planification today on the simulation is something which is really very useful. You need to have a plan, exactly what we do when you are an orthopedic surgeon to implant a hip arthroplasty or a knee arthroplasty, and now even the shoulder arthroplasty. They have a planification, and the results are, of course, much better with this kind of planification and simulation if you have softwares. So here's one of those software that we use, and we try to define the correction we want. And if you use those kind of platforms, you have engineers that propose you solution. And for this patient, they proposed me this planning, but I told them it's not really what I want. The problem is not there. What do you want me to do a PSO at L4? And the engineer told me, just because this is the most common level to do a PSO. I said, yes, but I treat patients. I don't treat only the statistics you have. This is the main problem of the artificial intelligence that they use, because the majority do that, so they propose you to do that. I say no. So they proposed me a second planification with more osteotomies. I say, this is not the reality. This patient has a pelvic incidence of 60 degrees, and he should have a higher low doses than this, and not such a long kyphosis on top. So finally, we did the PSO at the level L1, where the kyphosis was, because there was no kyphosis at all between L4 and S1. So we have to treat really the patient. Each patient is a problem, and we have to analyze the balance, and then we propose a solution. I'm not trying to put all the patients in the same box. So the pre-op examination is very important. And for this patient here, I show you this was a pre-bent rod that we got for the surgery, and this is exactly what we got after the surgery. So when the planification is well done, the osteotomy is planified at the right level, you really have a good outcome. And for this kind of surgery, of course, it's very important to use the perioperative monitoring because in some cases, we can have very bad surprises during the surgery. So it's very important to be very cautious and do this kind of monitoring, and to be sure that we don't overcorrect, for instance, or when creating the correction, we don't compress the spinal cord or something like that. So the classification we use for our regular osteotomy is based on the SRS classification with 6th grade from 1 to 6. And what we speak about today is the number 3, a little bit of the number 4 that we combine also with the PSO, because the transpediculodiscal osteotomy is really a very powerful technique. So the PSO concept, the transpedicular, the most common, it's a partial body resection as described first by Bridgewell, so posterior resection, and then an anterior triangular resection of the vertebral body, including the 2 pedicles and the posterior wall of the vertebral body. And doing so, when we close it, of course, we have a good correction. So the principles are, first, we implant the screws on the level above, on the level below. Why? Because the PSO technique is a bleeding technique. Even if we take a lot of tip and tricks to avoid that, there is a bleeding there. And it's better to start to put all the screws so that this work is done, and then we will perform the PSO. The resection, the limitation of the area that we want to resect is very important. In the past, we saw that we resected too much of the vertebra, so that the posterior part of the spine was not touching at the end of the surgery, and we created a lot of pseudarthrosis and with rod fracture after that. So we have to do a limited resection posteriorly, exactly what we want to do. This is the reason why the planification is so important. So the posterior arch removal, preserving the central part of the lamina, because this piece of bone will allow you to close completely posteriorly and to apply a very good bone graft after that. And the transverse process have to be removed, or at least cut and push laterally. So the inferior facet of the superior vertebra has to be resected. This inferior facet is really a problem, because if you don't resect it, it will compress the nerve root, the traversing nerve root at this level. So you have to remove completely the inferior facet of the superior vertebra. The pedicle preparation is, of course, very important. And inside the canal, you have always a lot of veins there, epidural veins that you have to coagulate to avoid bleedings. Then you perform your triangular resection of the lateral part of the vertebral body. And finally, the posterior wall resection and the resection or the compression of the osteoporotic bone inside the vertebral body to create a strong anterior wall in your body. So the pedicle subtraction osteotomy, we need to use different instruments to remove the bone, but the most important instrument for me is the burr, because it limits the bleeding. It allows you to do a very precise cut, and using this burr and some forceps to remove the piece of bone, this is the easiest way to do that. Today, you have a ultrasound system that allows you to cut the bone without bleeding too, It costs a little bit of money, but it's also very useful if you have access to this technology. So the posterior arch limit is very important. And as you can see here, I keep this inferior part of the body, of the lamina, of the vertebral body. I want, at the level I want to do the osteotomy. I keep this piece of bone because when we will close the osteotomy, this piece of bone will come in contact with the other one here. So you remove the posterior arch. You can do it using the Kerrison Ranger. It takes time. Using the burr, you create 2 rails there, and you can remove after that the bone with a big Ranger so that you can keep the bone for the graft after that. This is very important. The main thing is to avoid to make bleeding. So using the burr to do the 2 rails, one on top, one on bottom, and then you remove laterally the bone and you will see the spinal cord, or if it's below L1, all the nerve roots, of course. If you have already surgery before, there are some adherences, and it is important to resect the maximum of the fibrous tissue you have there. Because if you have a lot of fibrous tissue, when you will close the osteotomy, this fibrous tissue will compress the nerve root. So you have to remove the maximum of the fibrous tissue. And then you have to resect the inferior facet of the superior vertebra to avoid the nerve root entrapment during the osteotomy closure. This piece of bone here is very dangerous, so you have to remove it completely. On the lowest part, it is the same. You have to remove the facet there so that the nerve root will not be compressed. And then you localize the pedicle on both sides. It's nice to do the same hole as you do to put a screw so that you have the direction of the pedicle, and at the same time you will have the direction of your osteotomy. So it's very useful to determine where is the pedicle and to check on the C-arm, or if you navigate it, to check on the navigation that you are in the right direction. And then when you are inside the vertebral body, if it is an osteoporotic patient, old one, you can compress the cancellous bone inside the vertebral body. This will increase the stiffness of the anterior part of the vertebral body, which is very important to avoid a crash there when you close the osteotomy. So the eggshell technique is very useful for the elderly because it allows you to keep the maximum quantity of bone and to have a very strong anterior wall. So here I see we have some movie here. So after that, it is the time for the pedicle resection. It's an unblocked resection. So to do that, we use the
increase the post-op bleeding. Then special osteotomes.
So it's ungulated osteotome,
as you can see here,
circular or triangular, so that we can remove completely the pedicle in one piece, as you can see here, so that you limit the bleeding, but you remove already a very nice piece of bone on both sides. And then you have to go laterally here on the vertebral body. And here you have to detach the segmental vessels from the vertebral body. You can use the curb elevator to do that, and you push literally the segmental vessels laterally, and you pack a piece of surgical or something like that inside this lateral wall, because this will decrease the bleeding, and you can have the bleeding of the veins of the segmental vessels, but using this surgical, you will completely stop the bleeding there. So you have in a very nice area without blood. So you see laterally the vertebral body, and you will be able to cut it.
Lateral part of the L4 vertebra.
So we pack the surgical there. So you have the pin inside the pedicle. So you know where is the pedicle. You just need to follow the pedicle with your curb elevator. And here you have your osteotome, which is inside the vertebral body to remove the pedicle. So it's totally without bleeding because you just pack the surgical laterally. So you do that on both sides. Of course, you need to see the nerve root traverse nerve root which is there. So you increase the size of the hole, so you can tack the bone, or you can remove the bone using a ronger, and you do that on both sides. And after this lateral resection, you have to cut the posterior wall. So here the lateral resection can be done using this osteotome, but on the side to cut laterally. And the last thing is to cut the posterior wall. This is the most dangerous. We have to go below the dura. Sometimes the posterior longitudinal ligament is quite strong or calcified. You have to be very careful when glide this in just below the dura. You can even glide it below the ligament. And there are always small veins there that you coagulate before. But this osteotome will allow you to do a very nice, and you use it from one side to the middle, from the other side to the middle, on top, on bottom, and you can do a very nice resection. If you need to a very big osteotomy, of course, you increase the size of the resection at this level to do the osteotomy at this level. And as said by Pedro before, the majority of the PSO in the past were very limited. And I saw many papers, and when we did the study in France about 250 cases, people made an average PSO that was only 18 degrees, because the reasons are multiple, but one of the reasons is that the posterior resection was not so bad, but after that, they didn't pay attention to the complete correction, and finally they lost correction in their PSO level and also at the level above and below. So after that, you need to check that you have all the nerve roots. You can see the 4 nerve roots in your preparation. You need to stabilize the level. Here I will show you the trick I use to stabilize this, because before cutting the posterior wall, I stabilize the spine, because I don't want to have a complete break and to have some kind of luxation or big gliding at the level of the osteotomy. So I stabilize. You can stabilize with a small rod on one side using the screws that you have implanted. And I use another trick I will show you later. So here you have a better view. So all the screws are inserted. You see the nerve root on top, on both levels, top and bottom. You have here the dura, and of course the resected area on both sides with some surgical inside the vertebral body. Then the closure is the last step. So there are different techniques to do the closure of the osteotomy. Some people, they use the flexion of the table. So they extend the hip and the pelvis and they close it. With electric table, it's a smooth motion. Of course, you have to trust the guy who is flexing the table. He doesn't flex the table in the other direction, but it works well. My good friend Cedric in Lyon is using this, and it works very well. You can also use the compression on the screws. If the screw anchorage is good, you can do that easily. You can use also the domino technique, which is safer, I think, because you the load is on more screws, so you avoid to have screw loosening. And finally, another trick, which is the redux plier, I will show you. So here are the 3 steps. This patient was operated with the table motion. So the opening here, partial closure, you see that the dura is flexing a little bit, and the final closure, bone to bone. So this is the best way to avoid pseudarthrosis after. You can also use this kind of forceps just to close the osteotomy, applying the compression on the rod at the level on each side of the osteotomy. The risk when you do that is that you lose some height on the anterior part. It's very difficult to control really the correction. So sometimes you have performed a very nice osteotomy, and at the end you are disappointed because using this kind of technique, you lose the height in the front. Because what you have to do to control the osteotomy is to rotate. It's a rotating movement of the screws so that you keep the anterior height constant. And so you take advantage of your posterior osteotomy without losing the height in the front. So using an instrument like this one that is fixed on 2 levels above and 2 levels below, you have the load which is distributed on both sides to avoid screw loosening. And because this instrument is designed for that, you don't change the distance in the front. So you have the most powerful closure that you can have. So here are the different steps with this instrument. And at the end, you have the closure of the osteotomy. So here's the other technique using the compressor on the screws on top and bottom of the osteotomy. If the screw anchorage is good, you can do that. But in osteoporotic patient, I think you have to be very careful. It's better to use a domino technique. So you have a rod on top, rod on bottom, and the domino here. The main problem with the domino is that the domino is exactly at the level of the osteotomy. And sometimes when you want to have a very important closure, the domino is in your way and the screws of top and bottom are touching the domino and you can't completely achieve your closure. So this is a problem. So at the end, you have this, a very nice osteotomy with a triangular shape of your vertebral body and your rods are inside. So normally we put one rod first and the second rod after, not the 2 rods at the same time, but you can do both at the same time. The very important point is to have bone-to-bone contact posteriorly just to avoid pseudarthrosis. Here is the technique using this system, the Redux plier, and you will see that using this, so you have a progressive closure. The main advantage of this technique is that if you are not happy with the closure, because you have one piece of bone which is compressing the dura, or because one piece of facet is still there, compressing your nerve root, you can open it again, do what you have to do, and close it again. So this is really a nice way to do the osteotomy safely, and you make it very smoothly also to avoid a big breakage in the front. So here you have all the steps with the opening, the dura exposure, the nerve root exposure, and the closing at the end. So some example to show that it works, of course, and with a nice restoration of the lordosis in this patient. So there are associated gestures that we can add. Cages in adjacent disc, it is recommended. You can use the Zileli technique or a lateral Lilith after some time, after in the second step. But it's very important. If the discs are high and soft, it's very important to do fusion there. Otherwise, they will stay mobile a little bit, and there is a risk of failure with rod breakage. Iliac fixation is often recommended because if you do the PSO at L4, for instance, you have only L5 on S1 fixation, it's not enough to have a long construct. So iliac fixation is recommended with sacroiliac fixation and iliac fixation. Also, it's recommended if you don't have a very strong bone posteriorly because the patient was already operated before, to use double rods and domino also to avoid to apply too much compression on the screws. And here you can see that when you have a void like this in the front, it's better to do a secondary, in the second step, lateral fusion here, just to avoid to have pseudarthrosis. You can do the Zileli technique during the same procedure with the 2 cages inserted here in the same procedure, or do the lateral fusion in a second step that you can perform before or after the osteotomy. That depends on the case, of course. Bilateral 2 rods on each side is recommended in case of redo surgery because the constraints are very high, and without screws at all the level is really a big problem. So you have to double the rods there. So the transpediculo-discal, like Lemmer or Bergiano, you probably spoke about that before. The osteotomy transpedicular asymmetric, which is sometimes very useful to do scoliosis, and sometimes in very, very important deformity, double osteotomies, transpedicular, or triple osteotomies in very complex ankylosing spondylitis. So it's just a case here with a transpediculo-discal osteotomy, which is very powerful. You can do it at this level like this, and you have a very strong correction there. You have the closing opening wedge osteotomy, which is a little bit dangerous because you have to distract completely in the front. And the problem in this case is that you can avoid.
Öbür türlü disk orada sıkışıyor, sonra cage'i geri atıyor.
I don't know who is speaking. And you can have a vessels problem with the aorta, for instance. So I don't recommend this one. I do prefer the transpediculo-discal osteotomy because it provides really a very good correction. And when I do that, I always put a cage there. It's a mesh cage just to keep the disc open in the front. And really you can do a 40, 45 degrees correction using this technique. The PSO asymmetrical, this is the technique developed by Daniel Chopin. It was 20 years ago, and I saw it with him at this time. And so when you have to make this correction with very rigid scoliosis at this level, with a curve between L4 and L5, for instance, you do this asymmetrical resection on one side. You can even put a cage on the other side, and you do the PSO posteriorly. So doing so, it's very important to use the domino. Otherwise, you are unable to close this osteotomy properly using only one rod. So you fix one rod on top, one rod in bottom, and you manipulate the two rods at the same time to put them in the domino, and then to apply the compression to reduce. So this is the most important part of this surgery. This is the motion you have to do to close both sides at the same time to reduce the frontal plane and the lateral plane at the same time to have a good correction. So the domino is always applied on one side, and after that you put the second screws on the other side, or the second rod on the other side. So when you have a case like this one, this lady was operated, I think 6 or 7 times, and she went with this kind of fusion, which is not optimal, we can say, because maybe 13 degrees of offset on the AP view, and the lateral view was not perfect neither. But it's not so bad on lateral. So I decided to do an asymmetrical PSO in this case. And we obtained this alignment after. And the domino were used on both levels in this case because we wanted to connect with the level above. That was already instrumented. And here is the post-op images showing the good correction in AP on lateral. And I did that, I think it's 10 or 12 years ago because I saw this patient last month, and she came with a kid, and the kid was 9 years old. So I think it was almost 2 years before. And she refused to marry before, and she get married after the surgery, and she was pregnant after that. So in very complex cases like this kind of osteotomy, we have to perform 2-level osteotomy. It's of course risky on the neurological point of view and for the bleeding also. So don't start with this kind of osteotomy, but it is exactly the same technique that we apply. And in many cases, we did that at L4 or L5 for the first osteotomy, and T12 or L1 for the second osteotomy. And we obtain a good correction with this kind of technique. double osteotomy, L4 and L1 in this case. And to finish, the cervical osteotomy, it's possible to do PSO safely at the level C7 because the artery is not in the transverse process there, so it's much easier than at the other levels. So we can do a PSO there. It's mainly what I do, it's a transpediculodiscal osteotomy T1, which is really very powerful to reduce deformities at this level. Thank you.
Thank you, Jean-Charles. So, I think
Yes, great talk indeed, really. Many tips and tricks.
Yeah, the bleeding is really something that people are afraid of. Of course, they are afraid of the neurologic trouble, of course, but the bleeding is also, remember the first case I saw with Daniel Chopin was in 1990. So it's 31 years ago. And I remember at this time, the bleeding during the surgery was 4 liters. So it was really terrible. And this is the first PSO I saw, and I was a little bit afraid. But now, when you do a PSO using all the tip and tricks, you do progressively, you control everything. You have all the tricks you say, the tranexamic acid, you have the flow seal, you have all the techniques to decrease the bleeding. The anesthesiologist is very important because they have to control the blood pressure. They help us a lot for that. And you have to compress everywhere, all the bleeding area to decrease the bleeding. Today, for instance, I asked my anesthesiologist to check how much bleeding we had in the last 2 years, because I worked in a new team last 2 years. And we did only 41 osteotomy in 2 years. And the average bleeding was 900 cubic centimeter. So, which is not a lot compared to what we had before, where it was closer to 2 liters. So now it's less than 1 liter to do osteotomies. And sometimes it's definitively much less than that. So it is not such a complex surgery today for the bleeding if you have all the tips and tricks to control that.
yes. This is a very complete lecture, Jean-Charles. This is a very, I think the lecture should be studied several times. You know, there are all this experience and all the tricks in it, what your life with all these osteotomies has produced. So I think this is really something which can be seen again, and that's the advantage, that we can see this again, so we can restudy this lecture when we have it on the platform after that. So I think this is really a lecture which gives the basic input for all these osteotomies. Any questions from the audience, from the participants?
Onur, actually, there's one Turkish question that what is the disadvantage of anterior distraction in case of...
The anterior distraction was described by, what is the name of the SPO? Smith-Peterson. Smith-Peterson described his technique to treat ankylosing spondylitis. And what he did to have a good correction was to crack the spine in the front. And for those patients, they often have a calcified aorta, and he had aorta disruption in the front, and the patient died on the table. So anterior distraction of the vertebral body is something that should be done very carefully. You have to control the vessels before. So that means you have to do it like you do en bloc resection as described by Rockamille, and you have to put your finger to the front to be sure that you will not distract the vessels at the same time. So the anterior distraction of the vertebral body is dangerous.
But there's one question for the cervicothoracic junction. Professor Mohammed Fawz is telling that I find T2 PSO is better than T1. Do you accept that?
Oh yes, I think it's you have a stronger fixation if you put your fixation on C7 T1 and you do your PSO on T2. The problem is that sometimes we have a patient, trauma patient, where they have a fracture at C7 T1 and you have to do the correction at the level of the fracture. But I agree that if you have the choice, it's better to do it at T2 there.
And he says it is less risky for brachial plexus. Huh?
Yeah, probably.
Yeah.
Probably.
Any other questions, Onur?
And Charles, it was really a perfect presentation. The question is that in ankylosing spondylitis cases, you may need multiple PSO. So is there a way to, in the thoracic spine, if you need to apply and add a thoracic PSO, is there a way to reduce the neurological deficit? Because if you try to bring the bone to bone at the thoracic spine, sometimes it causes some changes in the neuromonitoring there. Do you have a trick there?
There is no real trick, but what we know is that PSO is better than VCR in the thoracic spine because there are more complications. But in some cases, we have to do VCR in the very young children. But for ankylosing spondylitis, we do small PSOs. It's better to do a small 2 or 3 small PSOs than one big one. If you do a big PSO with a very big angulation, you have more neurological problem than if you do small PSO. So in the thoracic spine, and particularly at the level T12 or T11, I do mainly transpediculodiscal because it's very powerful. It gives me with a small PSO, very strong correction. And, but everything has to be done progressively. And I participated, I was not the surgeon, the main surgeon, in a case in Asia where they had to do ankylosing spondylitis that was so big that we had to do 3 PSOs. But we did the surgery in 2 steps. So the first surgery we did, we put all the screws and we did 1 PSO, the most important one. And then we close and we wait for a couple of days to do the second step. And the patient was in better condition to do the 2 other ones. And finally, the correction was very good. So you have to do progressively. But the problem with this kind of big surgery is that the complication rate in the literature is close to 30%. So if you can reduce the infection rate, for instance, it's very important to reduce the time of the surgery. Less than 6 hours is very important. And to reduce the bleeding also, so you have more time. So there are a lot of tricks like this that we can use for these very complex cases.
And Charles, we usually do one briefing with the anesthesiologist after we have prepared, placed all the instrumentation, made our decompression, but not started the PSO. Because at that time, if we place the rods, we can send the patient safely to the room. So at that time, we check if the condition of the patient permits to proceed with the PSO. Do you think this is worth it considering systematically?
Oh yes, I trust that this way we do the same way. We always put the screws first, then we start the PSO, we do 1, if everything is fine, we say, can we continue or not? And in old patients, the experience showed that it's better to do it in 2 steps. In my experience, I did 50-50. But I never did more than 2 PSOs at the same time. So, but in old patients, you can wait, it's better.
John Charles, there is one question that you have shown some cases. you have done additional TLIF or lumbar lateral interbody fusion. Do you make those in second stage or at the same stage?
So for some patients, the TLIF were already done. So that means I have nothing to do, but done with a bad correction. So, but it's possible to do the TLIF during the same procedure. The main problem is that the TLIF at the level below the PSO is very easy. You have enough room to put your cage and everything. The problem is the TLIF at the level above the PSO, just at the level where the osteotomy is performed, because the end plate of the vertebral body is quite fragile at this level. And to do the TLIF there, you can break the end plate and you will lose correction there. This is the reason why if you do a transpediculodiscal, it solves the problem, because you have a strong correction and you put a big cage or a mesh in the front at the level of the disc, and you have a very good closure there. If you are not sure to do that, you do your PSO correction, and in the second step, you do the lateral fusion with a minimal invasive technique. The same day or the day, a couple of days later, it doesn't matter. You can even do that sometimes before and do your PSO after. Is a two independent surgery for me is the best. This is what I do normally. I do the lateral approach before or after to put the cage there, and then I do the posterior approach for the correction with the PSO.
One more question. How many levels should be fixed for a single PSO at T12 level? And which is the most fundamental in fixation, the lower or upper screws?
The main problem is to have a good balance after the surgery. So normally 2 levels, I mean 4 screws below the osteotomy and 3 levels, 6 screws on top for the angulating kyphosis should be enough. But the problem is that you have to be aware that you need to have a very good sagittal balance correction. And sometimes it's better to add 1 level below or 2 or 3 levels above to be sure that you have the lever arm is good and not finish your construct just at the apex of the thoracic spine, for instance. But mechanically, it's 2 levels below, 3 levels above, but you need to do your planification and don't stop your construct just at the apex of the thoracic spine.
Good.
Very good. So are there any other questions or unclear situations? Everybody's going home now doing all these osteotomies. Yes.
Good clinical exam and do the flexion extension X-ray. Yeah. Don't operate patient with good flexibility. It's better to do less complex surgery.
Yes. Yeah, it's very, very great talk of both of you, Pedro and Jean-Charles. Thanks a lot. I think we can leave the meeting here.
Yeah.
Do you wish to say something, Max Aebi?
No, I just want to thank Pedro and Jean-Charles for this excellent lectures, and I just want to repeat that if somebody wants to study more detailed these lectures, they can do that on. It will take probably 1 week or so, and then they can do it on the OOT platform. They can review the whole lectures and study them. So that's a big advantage of this meeting. And thank you, Onur, for organizing that with Mehmet. Thank you very much.
Thanks a lot. Goodbye.
Thank you. Bye-bye.
Good night.